In this presentation, we review the management of neuromuscular scoliosis. My name is Thomas Buell. I'm a neurosurgery resident at the University of Virginia. Neuromuscular disorders include conditions affecting upper and lower motor neurons, as well as myopathies. Pediatric spinal deformity is a common consequence of many neuromuscular disorders. Curves are often long and sweeping, of great magnitude, and with pelvic obliquity. Therefore, surgical correction often warrants pelvic instrumentation. This patient population often has significant comorbidities. Therefore, this partly explains the high associated surgical complication rates. However, over the past decade, studies have demonstrated reduced complication rates, partly attributed to technical and instrumentation advancements. Here is a classification of neuromuscular spinal deformity from the Scoliosis Research Society. Subdivisions include primary neuropathy and primary myopathy, with common examples listed. Scoliosis develops in approximately 70% of non-ambulatory patients with cerebral palsy, often by age 15 years. The long sweeping curves often include the pelvis, causing pelvic obliquity, and the resultant sagittal and coronal imbalance often warrants spinal pelvic fixation. Here's a case example of an 11-year, 4-month-old boy with cerebral palsy and neuromuscular scoliosis. Preoperative radiographs without a brace, in a brace, and in traction are demonstrated. The child underwent instrumented arthrodesis from T3 to S1 and placement of bilateral iliac screws. Postoperative imaging is shown after 21 months. Paralytic spinal deformity develops in more than 98% of skeletally immature children with spinal cord injury. More than 50% will be treated surgically. The development of spinal deformity is not typically related to a spine fracture, but instead seems to be primarily related to a spinal cord injury with lack of trunk motor control and spasticity. Patients with myelomeningocele frequently have spinal deformity. The more cephalad the last level of intact neurological function, the more likely spinal deformity will develop. More than 70% of patients who have a lowest level of neurological function at L3 or above experience deformity. Special considerations in this patient population include absence of lamina or dysplastic posterior elements, which may necessitate an anterior approach. Also, many patients have poor skin quality or scarring over the spinal defect, which may require tissue expanders in a collaboration with a plastic surgeon. Associated Chiari malformation and cord tethering generally should be addressed prior to spinal fusion. Pelvic fixation is often required. However, the iliac wings in these patients are often not wide enough to hold iliac screws. Alternatively, Dunn-McCarthy rods may be used with contouring of the rods in an S configuration such that the lower limb passes through the S1 foramen or over the sacral ala to sit in front of the sacrum. Here is a case example of a 12-year, 8-month-old girl with myelomeningocele and neuromuscular scoliosis. Preoperative sitting radiographs are demonstrated with and without traction. She underwent T2 to S1 instrumented arthrodesis with pelvic fixation using Dunn-McCarthy rods. Postoperative imaging is shown after 14 months. Several muscular dystrophies and myopathies are associated with the development of spinal deformity. Surgical treatment typically involves fusion with segmental instrumentation that is extended to the pelvis for pelvic obliquity greater than 15 degrees. Keep in mind that patients with muscle diseases may be more prone to malignant hyperthermia when exposed to anesthetic agents. Also, it is important to properly evaluate cardiac and pulmonary function in this group of patients. Restrictive lung disease from spinal deformity, coupled with decreased muscle function, can produce significant pulmonary compromise. Complication rates climb considerably when vital capacity falls below 40% of predicted. Non-operative treatments for neuromuscular deformities include bracing and customized wheelchair seating systems that provide support for the head, trunk, pelvis, and extremities. Although several studies suggest that bracing typically does not prevent deformity correction, it can provide support for young children and those with flexible spines. Neuromuscular curves are often sweeping and involve significant portions of the spine. The threshold for surgical treatment is not precisely defined, but typically curves greater than 50 degrees are considered for surgical treatment. Because of non-ambulatory status and often severe comorbidities, surgical correction in patients with neuromuscular deformities is associated with significant morbidity and mortality. A review of the Scoliosis Research Society Morbidity and Mortality Database demonstrated neuromuscular scoliosis had the highest rate of complications, followed by congenital scoliosis and then idiopathic scoliosis. Advances in spinal pelvic fixation have resulted in improved correction with lower rates of pseudarthrosis and decreased need for anterior release. The current mainstay of surgical treatment involves pedicle screw fixation with iliac or sacral alar iliac screw pelvic fixation. For scoliosis related to spinal cord injury, pedicle screw-only constructs may provide better correction than previously reported. The next slides focus on operative advancements such as sacral alar iliac screw pelvic fixation and a potential role of adjunctive minimally invasive surgery for lateral interbody fusion. A recent study aimed to assess correction of pelvic obliquity in children with cerebral palsy postoperatively in 5 years after posterior spinal fusion with pelvic fixation using unit rods, sacral alar iliac screws, or iliac screws. Implant-related complications and reoperations were most common in the iliac screw group. At 5 years follow-up, the iliac screw group had loss of major curve correction and less correction of pelvic obliquity than the unit rod and sacral alar iliac screw fixation groups. Additional studies demonstrated that low-profile pelvic fixation with sacral alar iliac screws produced better correction of pelvic obliquity than previous screw fixation techniques. Pelvic obliquity correction was maintained at long-term follow-up, and there were no cases of implant prominence or anchor migration. Surgical correction of spinal deformity in myelomeningocele is associated with high rates of pseudarthrosis and implant failure. In these patients, marginal posterior elements may be a limiting factor. An anterior approach may be utilized. Traditionally, a wide exposure from thorax to sacrum is used. This study demonstrated that minimally invasive lateral interbody fusion as an adjunct to posterior spinal fusion may provide acceptable fusion rates with less morbidity than a traditional open anterior approach. As previously mentioned, there are high complication rates associated with surgical correction of neuromuscular scoliosis. However, a recent report from the Scoliosis Research Society database demonstrated a substantial decrease in complications over the past decade. This decrease may be attributed to both the consistent usage of intrawound antibiotics and improved instrumentation. Additional studies have assessed risk factors for perioperative complications. Toll and colleagues demonstrated that neuromuscular scoliosis patients with pulmonary comorbidity and higher intraoperative blood loss have greatest risk of major perioperative complications. Other studies that focused on cerebral palsy patients undergoing deformity correction demonstrated risk factors that included greater preoperative kyphosis, staged procedures, lack of antifibrinolytic use, and increased intraoperative blood loss. The major perioperative complication rate was nearly 40%, with pulmonary complications being most common, in a recent series reported by Samdani and colleagues. Risk factors for perioperative wound infections. Janjua and colleagues assessed 102 patients with neuromuscular scoliosis who underwent deformity correction. The mean time to presentation of an infection was approximately 2 months. The perioperative deep wound infection rate was about 15%. Wound infection risk factors included pre- to post-operative increase in body weight, exaggerated residual lumbar lordosis at follow-up, pulmonary comorbidity, history of myelomeningocele repair, seizures, and previous operations. Despite the high complication rates associated with surgical correction of neuromuscular scoliosis, scoliosis surgery is associated with significant improvement in health-related quality of life at long-term follow-up. Also, a recent study demonstrated that the complication rates had no correlation with health-related quality of life changes postoperatively. These results suggest that the benefits of scoliosis surgery outweigh the complication risks. In conclusion, spinal deformity is a common consequence of many neuromuscular disorders, and surgical correction is associated with high complication rates. This may be partly attributed to the significant patient comorbidities in this population, as well as the long instrumentation constructs with pelvic fixation to correct pelvic obliquity. More recent advancements in technique and instrumentation have reduced these complication rates, and recent studies demonstrate that the benefits of surgery likely outweigh the risks in this fragile pediatric patient population.